This lesson has a number of topics having to do with eyes, ears, nose, and throat. And this slide set will take you through some of the conditions. And in addition, there will be student presentations covering some of the conditions. Before we launch into discussion of some of the eye conditions that we want to be sure to think about in a primary care setting with acute concerns, it's really a great idea to get a firm handle on the anatomy of the eye. This cartoon picture is fairly simplified, but it points to a couple of the things that I want to be sure folks are very comfortable with and understand. When we look at the person's eyes and we see their pupil, as you can see from this diagram, the pupil is basically an opening into the lens, and thus when we use our ophthalmoscope we can see right through to the optic nerve in the retina. The iris, which is the colored part of the eye, sits behind the anterior chamber and further behind the cornea. The cornea is the clear, kind of almost plastic-like covering that covers the iris. And from our point of view, we see, when we look towards the patient through the cornea, to see the iris and the pupil. The conjunctiva, the bulbar conjunctiva that comes and lays over the sclera, is the kind of thin layer of see-through membrane, if you will, that is what becomes injected or red-looking when a person has conjunctivitis of varying types. Sometimes neophyte students will confuse this with the sclera, which is the white of the eye, if you will, and that white structure can, of course, develop a inflammatory condition and become injected, but it is very rare. So most of the time when you look at an eye that has pink or redness to it, because there are blood vessels in the conjunctiva that are inflamed and enlarged. I've also referenced here the Ophtho book online, which is a fabulous resource and can give you some more basic anatomy from your reading list. Red eye, or in the case of a milder form of conjunctivitis, pink eye, is a very common complaint in primary care. Sometimes so very common, especially if we see a lot of children or younger adults, that we become a little blasé about the fact that it actually can signal something fairly serious. You'll see from the article that I posted on Blackboard and included in your reading list that red eye emergencies, of course, are not to be missed, and that there are key factors, which your book also discusses, in which that kind of point us away from the benign, common causes of red eye to the more serious and dangerous types. Let's just take a look at a typical case. So we have a 23-year-old female who reports to care with a chief complaint of red eye. She says that 2 days ago she developed red eye irritation with some yellowish discharge, and today both eyes feel irritated. Well, naturally enough, there is data missing here, right? We don't really have a sense of the full history of present illness. And so your questions, which may be even more questions than what I'm going to talk about, Really, first, of course, focus on how did this develop? Was it something sudden? Is it an ongoing problem, repeating? This looks like it's a fairly acute. It has been only 2 days. The clue about developing one eye irritated and then the second eye gives us some indication that this may be more on the bacterial side than viral or allergic. As you read in your textbook, that if we're thinking of the common causes and we kind of in our head are thinking of the common diagnoses of bacterial conjunctivitis, viral conjunctivitis, or allergic conjunctivitis, our history can help guide us a little bit. Now you also notice that she has had some yellowish discharge, and you might ask further, have her eyes been kind of glued shut in the morning with that discharge? And that again leads us more towards the bacterial conjunctivitis. Some of you are sitting there and saying, well, she's 23 and I'm thinking she might be sexually active, and we'd wonder whether she or her partners might have had any symptoms of sexually transmitted illness such as gonorrhea, because we know that gonococcal eye infections can exist in that situation. So we're still thinking kind of along the veins of common things. So what are the other questions that we need to know? Well, we need to know what makes it better or worse, right? And basically in this case she might say not much of anything. She's really just been kind of dealing with it. And some of you may say to yourself, also thinking, especially in a younger person, although older persons certainly use them as well, but she might be a person who uses contact lenses, which takes us down a whole different road and worries about eye infections associated with contact lenses and causing keratitis and other secondary infections in inflammatory responses because of the contact lens. So say she says, no, I don't use contact lenses. I don't wear glasses at all. Don't need to. And I don't have any symptoms of sexually transmitted illness, and nor does my partner. Again, nothing seems to help or make it worse. She has just been washing her eyes with warm water and taking away the discharge so that when she goes out, she doesn't have that showing. You'll also want to be sure to ask her about some red flags. And those red flags include whether or not she's having actual eye pain. Now, she'll have eye irritation and it won't feel very good, but she should not have eye pain if it's even a bacterial infection. If she was a contact lens wearer and did have pain, we would be very suspicious of keratitis. And so pain should not be present. And she should not report any changes in her visual acuity, which is another red flag sign in terms of her symptoms. So what if the story is a little bit different and the patient does have some pain in the eye? They tell you that they have experienced some eye trauma. They think they got something in their eye. They rubbed it. It seemed to resolve, and overnight they still feel the little irritation, but today now they're noticing some discharge, and it is unilateral. That kind of story leads us down the road of thinking about a corneal abrasion, or even a corneal foreign body, or a foreign body that has been trapped under the upper lid, which can be constantly irritating and scratching the cornea. So again, our story leads us down the path that takes us to where we're going to go when we go forward for our physical exam. So we now have kind of a working diagnosis in our head. we think that just by her story, she probably has a bacterial infection, bacterial conjunctivitis. Also, of course, she could have had a viral conjunctivitis. And the kinds of questions that might have led us down that pathway, the answers to which would be something like a concurrent runny nose, cold symptoms, whether or not she had kind of developed both at the same time, that would lead us more towards the virus. If she had a history of eczema and atopy, and reported that the symptoms had been ongoing and kind of vague for a couple of weeks, we would think more in the allergic realm. But right now, we're kind of thinking, again, either viral or bacterial conjunctivitis. Now, there's a whole list of things not to miss, and those things are listed out and well developed in that article, most of which, at least even symptom-wise, you can rule out fairly quickly. Patient doesn't have pain, she doesn't have photophobia, she's not having visual changes that she's noticed, and before you even start to examine her, you can feel pretty comfortable that your red flags and the do not miss diagnoses are safe. Even if we have a fairly well-defined differential in our mind when we see the patient, like the one in our example, there are some parts of the exam that I do regardless of the history, mostly to be sure that I do not miss any of the red flags or the eye emergencies that need immediate referral. As with anything, the exam should be systematic and kind of run through the same steps every time. Visual acuity is always done with Snellen testing, both eyes together as well as each eye individually. And there's only one exception to that, and that's with exposure to chemicals to the eye, in which case you're going to go ahead and test the pH of the eye contents and then flush with a neutral solution like normal saline or as directed by poison control. And the visual acuity is not done in advance on that one. Sometimes as well you'll give them a little topical anesthetic prior to flushing. After doing the visual acuity exam, which is often done by nursing personnel, you want to focus your exam again, but we're going to go ahead and every time, of course, observe the eye structures just as you were taught in assessment. In particular, you're looking here for lid swelling or erythema, which might indicate there's an orbital cellulitis going on. You're looking to see that the eye is not bulging outward, and that it is in its proper place. You're looking at the lid margins, looking for any signs of blepharitis or possibly a sty which may have produced some discharge and discomfort. Again, sometimes you can have a sty that isn't external and it may be internal and may kind of mimic a conjunctivitis situation. Then you're going to be looking at the conjunctiva overlaying the sclera. And in that conjunctiva, again, you're looking for what's called ciliary injection or the redness or pinkness that is characteristic of conjunctivitis and some of the other red eye conditions. Things that might kind of make you feel that this isn't just an ordinary conjunctivitis would be a distribution of that flush or erythema that is not diffuse. Generally, again, with conjunctivitis, viral or bacterial or allergic, yes, the distribution. Just a couple of comments about fairly diffuse.